Good morning. My name is Chandran Tanabalan, and I'm currently based at the Royal Marsden Hospital in London. I'd like to say many thanks to the organisers of this webinar and to SIU-UK for inviting me to talk to you today. It gives me great pleasure in presenting to you the reasons why routine small renal mass biopsies is unnecessary and harmful. The role of renal mass biopsy in the management of small renal mass remains controversial because of concerns over diagnostic accuracy, safety, and capacity to affect clinical management. The perceived benefit of renal mass biopsy is to inform risk stratification, prevent overtreatment of benign low-grade lesions, and guide treatment selection. The use of renal mass biopsy has increased over time, with the highest use demonstrated in ablative or systemic therapy, and approximately 1 in 5 patients undergoing radical nephrectomy or partial nephrectomy. With the increasing use of cross-sectional imaging, around 60% of diagnosed renal cell cancers are small renal masses. Our current practice has developed in order to more accurately diagnose these small renal masses, and up to as many as 30% of these may be benign. The role of active surveillance and ablative therapies has certainly increased as more small renal masses are being diagnosed, along with a growing cohort of older patients. But there's also an increased number of robotic partial nephrectomies being performed. This will correspond to the increased diagnosis of these small renal masses, as well as the increased number of centres with the availability of a robot. The use of renal mass biopsies has therefore increased with time, and with a growing evidence based on renal mass biopsies, some leading renal cancer units are currently routinely using renal mass biopsies as standard practice as part of the diagnostic workup of small renal masses. The indications for renal mass biopsies are shown in this slide from different urological and oncological societies. In the UK, on the whole, we follow the EAU guidance to a degree. This table shows the 2015 EAU guidance, which is essentially the same as the 2021 guidance for indeterminate renal masses, with the addition of biopsies can be useful for the suitable medical and surgical treatment strategy in the setting of metastatic disease. The common themes against the use of renal mass biopsies are predominantly cystic renal masses and very comorbid or frail patients, or where surgery is not planned and conservative management is the choice of treatment. Depending on where you are located in the world will also determine whether or not you will have a renal mass biopsy. Now, one of the pioneering centres of the world for renal mass biopsies was by Jewett and his colleagues, based out of Canada. This team really pioneered and led the charge for renal mass biopsy since the early 2000s. They have a pivotal seminal paper released in 2015. Yet, a survey of Canadian urologists in 2016 showed that only 12% are performing routine renal mass biopsies. But on the other hand, as I mentioned earlier, specialist renal cancer centres such as the Royal Free Hospital in London would advocate routine use of renal mass biopsies in the management of small renal masses. Now, renal mass biopsy is an invasive procedure. As with any invasive procedure, there will be contraindications, and these listed below are the main absolute and relative points for renal mass biopsies. There are common sense on the whole, but needs to be considered carefully within a multidisciplinary team approach, taking account the patient and tumour-related factors in order to minimise harm to the patient if renal mass biopsies are being performed. The technique and imaging modality is important when choosing to perform a renal mass biopsy. Now, renal mass biopsies can be performed under ultrasound or CT guidance with similar diagnostic yield. Core biopsy has shown to have superior diagnostic rates compared with fine needle aspiration alone, and guidelines would recommend multiple cores, 2 or 3, with a 16 to 18 gauge core needle using a coaxial system. There is a view that experienced uroradiologists dealing with large number of renal mass biopsies are better suited to performing this procedure in order to obtain an adequate histological sample. This is a crucial point, as it is vital that an accurate representation of small renal mass in question is taken in order that A, the sample is useful in the diagnosis, and B, to guide in the management of the patient. And this brings me on to my next slide, that signifies the complexity of making an accurate diagnosis when dealing with renal cell carcinomas. Renal cell carcinoma are a heterogeneous tumour type, and the concern is that renal mass biopsies may not be able to correctly diagnose these subtypes. The four main subtypes are clear cell, papillary, chromophobe, and collecting duct carcinomas. But there are over 10 further subtypes with inherited syndromes. Each of these subtypes has differing prognostic factors, from indolent to highly metastatic. Therefore, it is essential for correct diagnosis in order to appropriately manage these small renal masses. Two recent reviews have comprehensively evaluated the accuracy and harms of renal mass biopsy. Marconi et al., over 57 studies evaluated, comprising of over 5,000 patients, reported a median rate of diagnosis of renal mass biopsies of 92%. Core biopsies were reviewed by Patel in over 18 studies comprising over 2,000 men, and this demonstrated a sensitivity of 97.5% and specificity of 96.2% with a positive predictive value of 99.8%. But the key finding also was that renal mass biopsies had a very poor negative predictive value of only 68.5%. Non-diagnostic rates ranged from 0 up to 22.6%, so almost a quarter of renal mass biopsies were non-diagnostic. Repeat renal mass biopsies after an initial non-diagnostic biopsy does yield high diagnostic rates, ranging from 80 up to 100%, but often repeat biopsy is underutilized, and this is often due to poor patient compliance, due to often a poor experience following an initial first renal biopsy, and this is often due to pain. Predictors of non-diagnostic renal mass biopsies in small renal masses are smaller tumour size, often 2 centimeters and less, cystic masses, non-enhancing, less than 20 Hounsfield units, and skin to tumour distance of more than 13 centimeters. Now, due to the heterogeneous nature of renal cell carcinomas, positive predictive value of an oncocytoma based on a renal mass biopsy is only 67%, and many of these alternative diagnosis is related to the heterogeneity of the oncocytoma, and this can be also closely related to chromophobe renal cell carcinoma, and this was demonstrated by Patel's paper. Now, this is vitally important when we're placing patients on active surveillance following a renal mass biopsy result. Overall, complications secondary to renal mass biopsies are infrequent, but not insignificant, and patients need to be carefully counselled prior to a renal mass biopsy. Complications include perinephric hematoma, clinically significant pain, visible hematuria, pneumothorax, and hemorrhage. Clinically significant bleeding after renal mass biopsy is unusual and generally self-limited. Low volume centres or centres with inexperienced interventional radiologists who regularly perform renal mass biopsies may also choose inappropriate patients or inappropriate lesions, and these lesions may cause inadvertent injury to adjacent structures or increased risk of bleeding complications. However, the overall Clavien-Dindo grade is generally less than 2. The subject of pain, though, is not something to be taken lightly, and is often a reason why patients are not keen on having repeat biopsies. So, as I've alluded to, globally, more renal mass biopsies are being performed, but it is still not universal. There are risks associated with renal mass biopsies, which are small but not insignificant. There is a risk of inaccuracy due to heterogeneity of renal cell carcinomas as well. But does performing a renal mass biopsy actually change management? We know that with contrast-enhanced CT scan, an enhancing renal lesion of less than 4 cm, 80% of those will be malignant. Generally, if the patient is fit enough, we are going to offer these surgery, generally robotic partial nephrectomy. The prognosis for a patient with an incidentally detected small renal mass is favourable, with an estimated 5-year cancer-specific survival of 95 to 100%. However, those who subsequently develop metastases, which represent 2% of small renal masses, face a poor prognosis with a 5-year cancer-specific survival of 5 to 10%. But what we do know from the BOUS Renal Cancer Registry is that 20% of surgically operated patients do have benign histology. Therefore, indeterminate lesions on radiological parameters, these patients can actually be spared renal mass biopsies and potentially be placed on a surveillance pathway initially. Therefore, whilst I would not say that renal mass biopsies should not be used, I certainly would be an advocate for a more selective use of renal mass biopsies rather than a routine rollout of renal mass biopsies. Although renal mass biopsy demonstrates a reliable ability to determine the presence of malignancy and characterize histology in small renal masses, but it is limited for grade. Notably, 1/3 of patients with a non-diagnostic biopsy will harbour malignancy on surgical pathology. As mentioned earlier, renal mass biopsies have a poor negative predictive value of 68.5%. The risk of placing these potentially curable patients on an active surveillance pathway based purely on a renal mass biopsy result, which they could potentially be showing a low-grade or indolent histology, when in fact they could actually have a more malignant subtype with a more metastatic potential. This is a critical point to realise and understand for patients who may be on active surveillance protocols based on renal mass biopsy results. Now, do renal mass biopsies alter surgical outcomes? Patel's paper from Johns Hopkins, published in Urology Journal last year, was looking at whether renal mass biopsies can be associated with a reduction in surgery for patients with T1A N0M0 disease. Over 100,000 patients from 2004 to 15 were analysed using a national cancer database. As expected, biopsy rate increased from around 8% to 15%, and also non-surgical management increased from 11.7% to 15.6%. One other finding noted, though, was that pathological tumour upstaging occurred, and this occurred more frequently in patients undergoing renal mass biopsy, which remains statistically significant with an odds ratio of 1.31. And these findings are further supported by Salmazi's paper from UCLA Institute of Oncology. They looked at more than 24,000 patients where pathological upstaging occurred in 2.1% of the patient group. This is almost double the incidence compared to the non-renal mass biopsy group. And these studies conclude that renal mass biopsy is associated with a small but clinically significant increase in upstaging from a clinical T1A tumour to PT3A perinephric fat involvement. Now, what we do know is that T3A tumours have worse overall survival tumours compared to T1A tumours. However, the significance of this renal mass biopsy upstaging of these tumours is small and is unclear significance on overall survival. More studies are needed. So to conclude, are renal mass biopsies in small renal masses unnecessary? A one-size-fits-all approach would certainly be leading to over-biopsying a significant number of patients, whereby surgery was always destined. An individualized, patient-centered approach, noting comorbidities and tumor characteristics, should be done prior to routine renal mass biopsies. Are renal mass biopsies harmful? Looking at the evidence in relation to the actual biopsy itself, the answer would be no, but it is certainly not a risk-free investigation. It is invasive, and patients are not always keen on the thought of a renal biopsy, pain being an important factor. The harm from renal mass biopsy is basing too much decision-making purely on the result of the biopsy. The nature of renal cell carcinoma, heterogeneity, means that the approach leading to a growing cohort of active surveillance patients that would have previously been operated on is now an area that needs to be closely monitored going forward. Another harmful product can be the undeniably statistically significant pathological upstaging of these T1A lesions to PT3A lesions following a biopsy. More studies are desperately needed to ensure that potentially these consequences of pathological upstaging of renal mass biopsies are not harmful for the patients in the long term. Many thanks for listening to our presentation today, and I look forward to answering any questions you may have in the Q&A session at the end of this session. Thank you.